You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 13th, 2024. This week, I'll do a little bit more ESC recap, including the Scoff trial, fasting before cardiac cath, the Matterhorn trial, some humbling data with AI in 2 trials, and a reflection on the work of being a patient. Let's first talk about the Scoff trial. Let's start by saying that coronary angiography isn't what it used to be. In the old days, patients had large sheaths placed in the femoral artery. The doctor stuck the artery blindly. Ad hoc PCI, urgent CABG, and too often vascular surgery to repair damage to femoral arteries could sometimes be required. Basically, it was a big procedure. And I guess that's the reason that proponents felt patients needed to be in the fasting state. Of course, another reason, perhaps the more likely reason for requiring NPO after midnight is because that is what was done. It was habit or therapeutic fashion. Patients, therefore, were kept NPO. It's not the worst thing in the world to be fasting, though it is a buzzkill for many patients, and it may cause issues in patients with diabetes. A group from Newcastle, Australia, first author Daniel Ferreira, decided to test the dogma of fasting before cardiac procedures. European Heart Journal published a trial manuscript. Now, I say cardiac procedures because this wasn't just a trial of angiography. Slightly less than 1 in 5 procedures were devices, pacers, and ICDs, and lead revisions. Patients were randomized 1-to-1 to fasting as normal. That was 6 hours solid food and 2 hours clear liquid. Or no fasting requirements, and patients were encouraged to have regular meals, but they weren't mandated to do so. They had about 350 patients in each group. The primary endpoint was a composite of many things, including aspiration pneumonia, hypotension, hyper or hypoglycemia. They assessed the primary endpoint with a Bayesian approach, and the authors assessed this with non-inferiority. Secondary outcomes included patient satisfaction scores, new ventilation requirements, ICU admissions, 30-day readmissions, mortality, and pneumonias at 30 days. The first result was that those in the fasting arm had significantly longer solid food fasting, 13 hours versus 3 hours. The primary composite endpoint occurred in 19% of those in the fasting arm versus only 12% in the no fasting arm. Obviously significant and both non-inferior and superior. The nearly 7% higher rate was driven by higher rates of hypotension, high glucose, and low glucose. No patient in either group had an aspiration pneumonia. Secondary outcomes were not much different, and there were no severe outcomes related to the procedure, the fasting, or no fasting. Patient satisfaction scores were slightly higher in the no fasting group, though 15% of patients did not fill out a questionnaire. Now, the authors concluded that this data, quote, supports removing fasting requirements for patients undergoing cardiac catheterization lab procedures that require conscious sedation. So my comments. I really like this study. As I often say on this podcast, we need to put our dogmas to the RCT test. And so I congratulate the Newcastle team for doing this work. Seriously, you all, I highlight this work because de novo non-industry funded trials deserve encouragement. I also celebrate the Bayesian analytic method. Instead of p-values, they give us Bayes factors and probabilities. It was a beautiful thing to read, but in this trial, the differences were so obviously higher in the fasting arm that no statistics were even needed. But But I want to push back on the conclusion that this data supports removing the fasting requirement. My reason for pushing back is, number one, fasting is not that big of a deal. I often say Jesus went 40 days. I don't say that to patients, but I say it to myself and sometimes to our team. What we aim to prevent in fasting is prevention of that one rare complication. Each group had 350 patients per arm, and that's a lot, but our cath labs may do thousands of cases a year. If even one patient has a terrible aspiration event due to having a full stomach, then the no fasting policy fails. The authors showed that milder events like blood sugar levels drove the results of this trial. Big events like aspiration or ICU visits or death were 0 in each arm. So I guess my point is that I'm not sure they can exclude the possibility of terrible but rare events occurring with only 700 patients in a trial. For instance, let's say a coronary angiogram turns into a complex PCI requiring LV support. Do you really want that patient to have pancakes and bacon in their stomach? Also, Australia's sedation practices are different from here in Kentucky. The average medelasone dose was 1 milligram, and average fentanyl dose in this trial was 40 milligrams. We give tons more for our device procedures. Americans in general require lots of sedation. And the authors allude to this in the limitations. They write that devices were only 15% of the cohort, and of course this limits generalizability to device surgeries, and I agree strongly with that comment. While I like this study and conclude from it that the signal is surely pointing toward no differences in fasting or no fasting when procedures are done like they are in Newcastle, Australia, but I would like to see more data before changing a policy. I could see cluster randomized trials wherein entire cath labs or hospitals are randomized. I'd like to see data in thousands of cases. Finally, though, one conclusion I would make from this study is that the non-thinking cancellation of procedures due to strict fasting rules should be stopped. There is room for clinical judgment, right? For instance, a patient who's traveled 2 hours for his pacemaker generator change, but ate a small breakfast or had some coffee with milk, we can still do these patients, especially when light sedation is planned. Next topic is functional MR. I covered the Reshape HF trial of transcatheter edge-to-edge repair versus medical therapy in patients with heart failure and reduced ejection fraction and functional MR last week. Reshape HF was positive, but it was driven by heart failure hospitalizations and quality of life measures, not CV death. And that's a problem because it was an open label trial. This week, let's review the Matterhorn trial. This is an RCT in 210 patients with functional MR. One group got mitral valve surgery, and the other got transcatheter edge-to-edge repair. The first author, Stefan Baldus, New England Journal of Medicine, published a paper. They enrolled 70-year-old patients with a mean LVEF of 43%. Pause there for a second and note the differences with the TER versus medical trials. 43% is a pretty good ejection fraction. In Reshape, 32%, COAP 31%, and MicroFR 33%. The primary endpoint of Matterhorn was a composite of death, heart failure hospitalizations, mitral valve reinterventions, LV assist device implant, or stroke within 1 year. Note here the many components of the primary as well as the 1 year follow-up. And whenever you have short follow-up of a surgery versus something else trial, there's going to be bias against the surgery trial. They also used a non-inferiority analytic method, and it's important to consider how this was set up. I'll get into the weeds just a tiny bit. They expected a primary endpoint in 35% of both groups. They also used a risk difference, an absolute risk difference for non-inferiority margin. And we need to remember that number because event rates that come out lower make it easier to reach non-inferiority when absolute differences are chosen as the non-inferiority margin. Here, the absolute difference chosen as the margin was 17.5%, so TEER could be declared non-inferior if the upper bound of the risk difference was less than 17.5%. And so if you think about it, 35%, 17.5% risk margin, you're looking at a relative risk of about 50% higher. But the results of Matterhorn, 16.7% of patients in the TEER arm had an endpoint versus 22.5% of patients in the surgery arm. So the risk difference was minus 6%, and the 95% confidence intervals go from minus 17 percentage points better to 6% worse. So since 6%, the worst case scenario, is less than 17.5%, the transcatheter edge-to-edge repair is declared non-inferior. But you can see the problem, right? Instead of getting 35% endpoint rate, the TEER group had only 16.7. So it's really, really easy to meet non-inferiority. Had the expected event rate been estimated more accurately, they would have had to choose a much tighter non-inferiority margin. Now, they also report safety endpoints, and it is 15% for transcatheter edge-to-edge repair versus 55% for surgery. But most of the higher rates of safety endpoints in the surgery arm were bleeding and atrial fibrillation, which, I'm sorry, is kind of ridiculous because bleeding and atrial fibrillation are expected and known after heart surgery. New England Journal of Medicine displays a Kaplan-Meier curve for the primary endpoint, and the curves are coming together at 400 days, 1 year. So it makes me wonder what a 2-year endpoint would look like. New England Journal of Medicine also displays a death curve. There were 8 versus 9 at 1 year, and the one death causes separation of the curves at the end. And it's a really silly-looking curve because it makes one death look significant when it is surely just noise. For secondary endpoints, the authors chose recurrence of MR 3 or 4 plus, which favored surgery. Now, surgeon Victor Diane writes on Twitter that in a young lower-risk cohort, which this was, 70-year-old, 43% ejection fraction, it would be more important to look at recurrences of more milder forms of MR because even 2 plus MR predicts the need for more intervention. Here, surgery also favored recurrence of 2 plus MR. It was 12% versus 27%. Also notable is that 53% of surgery patients had 0 MR versus only 16% of the transcatheter edge-to-edge repair patients. Another peculiar difference was that almost 3 times as many patients in the TEER group had triple medical therapy at discharge from the hospital. That difference, of course, could have driven outcomes, or that difference could be a result of transcatheter edge-to-edge repair patients being less beat up and more able to take medical therapy. Now, when I first looked at Matterhorn when ESC was happening, I thought it was a problem trial because we hadn't yet established the transcatheter edge-to-edge repair benefit over medical therapy. And that, I think, is still true because of the divergent MITRA-FR and COAPT trials, and the fact that the ReShape-HF trial enrolled less severely ill patients and had positive results for transcatheter edge-to-edge repair, but it was driven by endpoints susceptible to open-label bias. But now that I look closer, Matterhorn enrolled different patients. The ejection fraction was much higher, the effective regurgitant orifice area much lower, and half the patients had MR due to ventricular tethering rather than just annular dilatation that we see in severe heart failure. Still, though, if they included medical therapy and only had outcomes at 1 year, I wonder how that would have turned out. Medical therapy might have done well. A surgery versus transcatheter edge-to-edge repair comparison was reasonable. The problem here was it wasn't a fair comparison. Endpoints at a year for 70-year-old patients with decent ejection fractions is not only not helpful, it makes me a little cynical about industry influence since industry funded this trial. Because everyone knows that cardiovascular surgery makes for a tough first year. I mean, the STITCH trial of CABG versus medicine in patients with severe coronary disease and LV dysfunction took 10 years to show a benefit over surgery over medicines. So when you choose 1 year follow-up, you make users of evidence think you are biased for the device. It may not be true. It may not be true, but it looks that way. What's more, the non-inferiority calculations of this trial are way off. You have a 16% incidence of events in the transcatheter arm and a margin of 17%. To me, that looks like outcomes could be twice as bad and still be non-inferior. It's also cynicism-inducing when you include AF and bleeding in the first year as safety signals. Everyone knows you see more of that in the CV surgery, so I say, why include it? A patient with severe mitral regurgitation, relatively preserved LV function, has to choose between surgery and transcatheter repair. Before they accept the newer and less invasive procedure, we should be able to offer them stronger data with longer follow-up. I still believe transcatheter edge-to-edge repair can be a helpful procedure, but I do not see Matterhorn as a reason to extend its use to patients who are amenable to surgery. Okay, next two trials are artificial intelligence. Let's first do the Rapid X AI trial. I'm an older doctor, so I'm drawn to studies that show new things aren't better than current standards. That's the teaser. Dr. Derek Chu from Australia presented the results of the Rapid X AI RCT at ESC. There isn't a paper yet, so this is a preliminary report based on his presentation and slides. Here is a brief discussion of the Rapid X AI project. Of course, it aims to test whether using computer programs in emergency departments can assist docs in providing better care for patients with symptoms related to chest pain. And the project involves the development of these algorithms that compare a patient's health information with a vast database of past ED patients. These programs use and identify similarities in variables like age, symptoms, health status. And by analyzing treatments and recovery patterns of similar patients, the algorithms can potentially support doctors in making improved decisions and suggesting more personalized care. The trial, and thank goodness there was a trial, was a cluster randomized trial in 14,000 patients in 12 hospitals, 6 city, 6 rural hospitals in South Australia. The EDs were randomized, not patients, right? Cluster randomized. Control arm got standard practice. Active arm got the AI-based clinical support. The primary endpoint was a typical composite of CV deaths, recurrent MI, and cardiovascular readmissions within 6 months, and it was nearly identical between the control and intervention groups. I listened to the recording. One of the discussants pointed out the obvious, that a good doctor armed with current risk calculators is pretty darn good, hard to beat. The other discussant noted that this is the beginning of an era of evaluating AI use in medicine. I look forward to this paper and then the discussion that follows that paper. My opinion on AI in medicine is not much more informed than a medical student's, but I would say that A, we need to continue to force any of these new algorithms to face the test of an RCD. So good on Dr. Chu and his team. B, there are likely places where AI will shine and places where it will not. Chest pain emergency department evaluation is not likely one where AI is going to help very much. Here's my thinking. The problem in chest pain evaluations in emergency department is identification of 4 to 5 sigma rare events, the 1 in 1,000 patients that have a missed MI. These are so rare that I doubt any system can help. What would help, I propose, is a more realistic culture wherein we speak plainly about an acceptable miss percentage. For if we keep that miss percentage goal at 0, we will continue to overtest, overtreat, and harm people via this zero failure quest. Now, a place I would expect AI to help is in ECG reading. It boggles my mind that we still have Commodore 64 level technology putting computer reads on ECGs. Everyone knows that they're wrong often, but we still keep putting those stupid reads on top of the ECG. Someone in artificial intelligence and machine learning, please develop an algorithm for ECG reading, not just for STEMIs, but in everyday regular reads. Finally, is it not conceivable that machine learning will help us with stroke prediction in patients with AF? I mean, we have the CHADS-VAS score, or I guess now just the CHADS-VAS score. But to me, it seems like machine learning could incorporate much more data than just this integer score and come out with a better predictive score. Maybe I'm wrong. Let me know. All right, second AI paper real quick. Proteus. This was the Proteus trial. Another place AI seems not to work is in its use for interpreting stress echo. So also at ESC, Proteus is a UK-based trial in 2,500 patients comparing an AI image analysis report during image interpretation versus just standard stress echo interpretation. Now, before I tell you the results, let me say that stress echo readings make me smile. I trained in Indiana and all we did was stress echo, but still, I look at them today, 25 years later, and my partner says, John, there's clear hypokinesis in this or that wall. And I'm like, okay, if you say so. It's totally different than what we do in the EP lab with direct measurements and calipers. Anyways, it would seem to me that AI would help because it's about pattern recognition. The primary endpoint of Proteus was severe CAD or evidence of an event at 6 months. It was assessed by the area under the receiver operating characteristic curve, and, in sum, there was no difference in performance. Both approaches, AI versus eyeballing it, had a 99% specificity and no significant differences in sensitivity, negative or positive predictive value. One interesting subgroup that was made a lot of at the time of the presentation was that centers with lower stress echo rates seemed to do better with the AI tool, but this is a subgroup of a negative trial. So my comments, again, I commend the authors for doing this. Presenting author was Ross Upton from the University of Oxford. Imagine a world, my friends, where these products are just marketed to gullible docs, perhaps over nice lunches in the clinic. I am not nearly as enthusiastic as some of the trial discussants who are enthusiastic and hardly deterred by the negative results of the Proteus trial. So I guess I would conclude by saying, yes, surely there is more work to do. AI will have more iterations. There'll be more AI testing. But I believe that at least currently, our Bayesian priors regarding AI disrupting current care defaults should be pessimistic. And if it's pessimistic, it would take strong data to overcome these priors. Or, in other words, decades of practicing clinical medicine count for a lot. All right, final topic today, the work of being a patient. I want to delve outside of pure cardiology for a moment, but I will come back to it. This is a paper I saw from my thoughtful list of docs on Twitter. It was an observational study and that quantified something they called time toxicity among older patients with cancer who are receiving palliative systemic therapy. I know. It's an oncology paper. It's in the journal Supportive Care in Cancer. Enrico Soto is a senior author. A PhD candidate, Jussi Baltlussen, first author. The study comes out of Mexico City, for perhaps a first for This Week in Cardiology. This was a simple but profound study. 158 patients receiving chemotherapy, about 3/4 of them were frail. Within the first 6 months, patients spent a mean of 21% of days with healthcare contact, 1 in 5 days. Now, I don't think cardiologists think enough about this concept of time toxicity. It comes up when I discuss rate versus rhythm control. All we hear about in EP meetings is East AF net and the early ablation trials, early rhythm control is better than rate control. But the thing is that rhythm control comes with a lot of time toxicity. There are days for cardioversions, days for in-hospital initiation of drugs, days for procedures, days from recovery from procedures, and days from dealing with recurrences. In rate control, the patient goes on a medicine, an anticoagulant, and is seen a couple times per year. There's almost no time toxicity. Now, I agree that for younger, highly symptomatic patients or those with a decent chance of rhythm control success, the time toxicity is worth it. But the degree of symptoms relative to the baseline comorbidity is often not worth the time toxicity. I discuss with patients how hard rhythm control can be on them, but many doctors don't. Now, another place time toxicity comes up in cardiology is guideline-directed medical therapy in heart failure. Again, I agree, a young patient, a 55-year-old with a bad ventricle and heart failure and no other comorbid conditions and good blood pressure ought to be encouraged to take aggressive up-titration of meds, no matter how much time in clinic it takes. Because in these patients, like those in the trials, outcomes are modifiable. But it's a totally different story for older patients with frailty or less than robust social support or multiple conditions. For these patients, get with a guidelines type treatment is a disaster. For these patients, we ought to find the best tolerated minimalist approach, what drug or drugs give this patient the best benefit with the least impingement on living life. For instance, it makes no sense to prescribe an ARNI when a patient cannot afford it. Why not use a simple ACE inhibitor? Mayo Clinic endocrinologist Victor Montori has written extensively on helping design the most minimally disruptive therapy. And I think while we work to achieve the best outcomes for our patients, we should always remember that people are supposed to have lives to live. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider writing us a review, give us a rating. This way others can find us. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.